On a winter afternoon in Afghanistan, my colleagues and I were busy in the gym when the trauma pagers suddenly sounded. American and British colleagues alike stopped what they were doing, grabbed their weapons, and ran about the door toward the hospital. We knew that a casualty was on the way, but we had no way of anticipating the severity. This was typical, and so we always planned for the worst case. Surgeons, anesthesiologists, emergency docs, and support personnel all came together within minutes. Our individual specialties didn't matter, and our egos couldn't get in the way. Our only concern at that time was for the patient that was on his way to us. As a combat resuscitation unit, we had come together, trained, and developed our skills as a team. Our environment dictated that we all had to be better every single time than any of us had ever accomplished individually. Our commander jokingly termed it world record trauma care, where our performance didn't matter. And how we performed in the next few minutes would determine whether this man survived or went home in a box. The sudden sound of the helicopter overhead on its descent into the helipad alerted us to the patient's arrival, and its odd approach hinted at the patient's condition. From the radio, the flight physician's report, as usual, was concise and to the point. 24-year-old male, IED blast, multiple gunshot wounds, op vampire initiated, vital signs lost on the ramp. As the patient was brought in, we could see that he was a young British soldier, covered in the Afghan soil and in his own blood. 3 of his 4 extremities were missing. The remaining was mangled. Despite the brutality of the injury before us, we moved forward like we had so many times before, just like we had trained. Our processes were in place, we had standardized our protocols, and we communicated effortlessly. Our function was machine-like in nature, which helped us to complete a tremendous amount of work in a very short period of time. But it also helped us to display some of the emotion that is involved in this type of work. The support and input of each team member was what made any hope of success possible. As we executed our plan and worked to ensure this man's survival, we began to make headway toward our goal. After several hours, we moved our surviving service member to a waiting aircraft to send him home to definitive care in the UK. Now, not every effort in medicine results in a win, but by structuring services as part of a team, motivated by a common goal, and powered by effective communication, outcomes can be improved beyond what one would consider possible. This is the type of environment that my medical career developed in, so collaboration and teamwork were normal. It wasn't until I left military medicine, and specifically deployed military medicine, that I realized that my normal wasn't universal. In the spring of 2015, I moved into a new position at a major level 1 academic trauma center, where I was excited to return to the trauma team dynamic. I looked forward to working at this university, which is a nationally ranked and recognized top hospital in a number of specialties. Almost immediately, though, I recognized that the dynamic that I so desired was glaringly absent. It was around this time that I first became familiar with the term care silo. The term care silo refers to individual medical specialties practicing in a vertically contained manner. When this concept is illustrated, it has an appearance similar to a silo, like you'd see on a farm. It appears as a tall and skinny column. As capability in a care silo grows, it extends vertically, but it does not overlap other specialties in a horizontal plane. Excellent care may be provided within the silo, but its full potential will never be met. Where silos exist, there are inefficiencies, redundancy of services, and gaps in coverage. This leads to suboptimal care. This is often the result of failures in communication, and lack of collaboration. My trauma experience at this same facility serves as a prime example. While attending to my first trauma case as a new faculty, I discovered that we, as anesthesiologists, had no access to the patients in the emergency department's trauma bay. Because of this, we had no insight into the patient's condition, efforts at resuscitation, or the surgical needs of the patient. Instead, we waited for the trauma surgeons to call and tell us the patient needed surgery and was on his way to us. This kind of last-minute notification meant that we had to pull our trauma team from the available personnel, instead of from a pool of trained and experienced providers that were used to doing these type of cases. Although every single provider that we had did their very best to provide great care, this system does not work as well. In this hospital, emergency medicine, trauma surgery, and my specialty, anesthesia, we all existed in our own independent silos. Each service was excellent in its own right, but when a task required cross-specialty collaboration, shortcomings in the system became apparent. As someone who had experienced a system where silos had been dismantled in the interest of patient care, I was deeply disappointed. I wanted better for my patients, and I wanted better for this hospital. As I began to work on processes to improve cross-service collaboration, I became aware of a concept that promotes the establishment of inter-service teams organized specifically to improve patient outcomes. In this concept, anesthesiologists, surgeons work together to return patients back to normal function in a shorter period of time and with fewer complications. The perioperative surgical home, as it is called, is a concept that promotes and supports collaboration between the patient, anesthesia, surgery, and supporting specialties. Using available research and best practice guidelines, anesthesiologists and surgeons specifically work to standardize care protocols for specific patient populations. The end goal of this effort is a patient who has less pain after surgery, a shortened hospital stay, fewer complications, and a rapid return to normal function. It is better quality care that's good for patients, it's good for physicians, and it's better for the hospitals. And this model can work for any specialty and any type of medicine. It is simply a method to bring together various specialties, establish lines of communication, and allow for collaborative care of patients. Now, that sounds simple, right? Yet we see poor communication and cooperation hinder medical care on a daily basis. One example is in pain management. Chronic pain is a major healthcare issue for our country, and in 2010 it was estimated that the total cost of chronic pain in America for our patients was up to $635 billion per year. That's more than heart disease, cancer, and diabetes. And pain is widespread, affecting more than 100 million Americans, more than heart disease, cancer, diabetes, and stroke combined. The reasons for the development of pain are many, but significant contributors are trauma and surgical care, after which these patients may be prescribed opioid medications. For many, this is the beginning of a lifetime of struggle against opioid addiction. To help prevent this, teams like those comprising this perioperative surgical home work together to develop strategies that take advantage of alternative pain control methods, such as numbing medication, injections, and non-opioid medicines. And this will provide optimal function after surgery. Patient nutrition and education are also considered. Because of the additional investment placed in these patients, complications are decreased. Pain is more appropriately controlled, and patients go home sooner. In fact, many of my current patients receive no opioid medications during their entire stay in the hospital, yet they report excellent pain control. This is the type of optimal care that anyone can provide with just a little forethought and collaboration. The bottom line here is that we have a better way to provide care to our patients. By working together as a team, planning ahead, and communicating effectively, we can help our patients return to healthy, functional lives with minimal complications. So if you are a provider, evaluate your own practice. Are you working in a silo? And if you are, how can you dismantle it? How can you be more collaborative and communicate more effectively with your colleagues? How can you better share information with those around you? And how can you share your experiences? Is your team focused on patient outcomes? If you're a patient who requires medical care, talk to your provider. Ask about the team that will be caring for you. And I say team, because it's a team effort. Ask about the team that will be caring for you and ensure that they communicate effectively. Know that you have options and that you can ask questions. This is your life and your outcome. We want you to demand better. It's my hope that this afternoon I provide just a little spark of inspiration to dismantle the silos that limit our potential as healthcare providers, and to venture out from the established norms to seek better outcomes for our patients. Better quality care is out there. We just simply have to work together for it. Thank you.